Well, a warm welcome to this video and welcome to Marc Girardot from Paris, I believe you're in, Marc, at the moment.
Yes, I'm in Paris. Thanks for hosting me.
Now, I've been reading your scientific materials and your publications over the past couple of days, and very impressive body of work that you've done. You must have done this virtually full time over the last couple of years. You've certainly been very, very busy with it. Just give us an outline of what your concerns are, Marc, if you wouldn't mind, please, and the implications of your work.
My main concern has been very close to your concern regarding aspiration. I've taken it a few notches down or up, whichever one you would say. So my main concern immediately when we knew that the particles were not staying in the muscles, I was immediately concerned. Okay. Why was I concerned? Because those particles are cytotoxic. What they typically do is they, by inserting themselves into healthy cells, they signal to the immune system for the destruction of that cell. That in and of itself is very dangerous. Remember, the amount of nanoparticles of these vaccines is between 10 and 50 billion, depending on the manufacturer. So it's enormous, and a 1 centimeter diameter of endothelium is about 60,000 cells. So you see that you can actually drill a hole with a very small fraction of the dose that's injected. So that was my main concern, and you inspired me, John. To be honest with you, it helped me get to understand better what was going on. And what I'm concerned fundamentally is that there is a considerable number of vessels in the deltoid, in muscles in general. Anybody who's eaten meat can testify that there's blood vessels in muscles, and there's this very old idea, preconceived idea in the medical industry that it's extremely rare to do an intravenous injection inside the muscle. Everybody has this idea of 1 in 10,000, and I was physiologically, this doesn't make sense. I'm a consultant in strategy. I'm also an entrepreneur, and what you do as an entrepreneur is you need to have ballpark figures. Clearly, it cannot be 1 in 10,000. So I spent a lot of time trying to figure out what the numbers was, and discovered I triangulated different ways. Aspiration, as you know, was a technique developed because of problems tied to intravascular injections. Therefore, it has a reality and it's material for people to have built that. That's the first point. The second point I was afraid of is through a discussion I've had with some friends at Heart in the UK, notably my friend Jonathan Engler, is that it's not necessarily clear that aspiration is good enough. And actually, there's the experience of bodybuilders with steroids that has shown that despite aspiration, they still inject about 2% of the time intravenously. And there's a number of other studies that I shared with you from steroids injections that show similar levels, which means that it's a reality that likely at a minimum 2%, possibly up to 5%, if we consider Professor Hoiby 60% reduction of aspiration, that 5% of shots are intravenously done by accident. Okay, by accident. It doesn't mean fully done. It doesn't mean it's always the case 100%. There's a whole range, obviously, of that. Sometimes it might be 1% of the dose going. Sometimes it's 100% of the dose. Now, the problem with that is that people in the pharma industry or the medical industry know full well what happens when you inject intravenously a product and you push on the plunger rapidly, like it's been advertised to do for the past 3 years, or 2 years, sorry. And that's the creation of what's called a bolus. And a bolus is a swarm of particles, if you will. One of my first articles, I don't know if you read it, had the analogy of those bouncing balls in San Francisco, down the hills of San Francisco. It's exactly what's going on. Okay, so just have a visualization of all these balls bouncing into our bloodstream in a very concentrated way. Now, so that's the bolus theory, and I've articulated it along six pathologies, which are, the first one is famous. It's basically anaphylaxis, and anaphylaxis is basically the most likely the most intense one, and you can have that with pollen. You can have that with vaccines, of course. You can have it with proteins. You can have it with fillers, anything. It will saturate the cells at a local level and potentially kill you. Okay, that's really anaphylaxis. Everybody knows about it. Some people say it's allergy related. Fundamentally, it's overwhelming a place in your body with a foreign material. I'm going to leave it aside. It's because it's more famous. After that, there's really 5 pathologies. 4 are related to the cytotoxic aspect of the NLPs, and 1 is related to the fact that some cells are immune privileged and therefore cannot be destroyed by the immune system, and therefore we have a different pathologies that occurs because we're tinkering with the internal of those cells, and I'll get to that. So you have the first 4 are fundamentally the same the same process going on with 4 different pathologies or mechanisms of action. The first one is arterial rupture, related to a very tightly concentrated transfection, which ends up stripping the endothelium, which ends up decaying because the what's behind the endothelium, the smooth muscle layer, will decay over time and will rupture. The second one is a bit more complicated, and I sent you something earlier. I'll go into the detail. I'm very excited about it. It explains thrombosis physically through 1,000 cuts into the endothelium. So that's faster. It explains deep vein thrombosis. It explains partially strokes also. The third pathology is the same process going on, but further down. Further disseminated in the organs. When the cuts happens in the organs, in the capillaries, they're going to clot the capillaries, follows necrosis, clotting and necrosis, and you're going to have a number of different scenarios depending on the severity, whereby a certain percentage or the integral part of the organ will be destroyed, and you'll have organ failure. It could be the lungs, it could be heart, of course, kidneys, etc. And the fourth one is in my view one of the most insightful elements of the bolus theory. And it's the idea that when you push this bolus theory further down, disseminated it more, what's going to happen? It's going to create small holes into the endothelium, right? So you're going to have much smaller transfection area, And it's going to, I think the term in English is, it's going to transform your endothelium like into a sieve. I think that's the term. And the endothelium is the blood tissue barrier in all of those organs, and therefore it's going to trigger a whole variety of illnesses that I'll touch upon later in the discussion. And the third, so the last leg is around the cells that are not going to get destroyed by the immune system because they're immune privileged. And those cells are immune privileged because they are very special. They're special because they're stem cells. They're stem cells that serve three purposes: blood, red blood cells generation, immune cells generation, and regeneration of tissue and cartilage and everything. So obviously they cannot be scuttled. At least evolution, we've evolved so that you don't scuttle those. They're too precious. And therefore, what it does is, in my view, it triggers dysfunctions, intracellular dysfunctions that could be and is likely related to cancer. Right? Because these cells are on the top of a pyramid, and if you let me make an analogy. If you put sand into a refinery, right, and you start providing petrol or gasoline to the entire world with that oil, everybody is going to have problems with their cars, right? That's the equivalent to transfecting a stem cell, and I believe it's starting cancer. That's the part of my theory that is the lightest. I'm gonna say. I think it's very strong. I think it's very consistent, but still I haven't investigated it enough. The rest of the theory, there's no question. It's a domino effect, and it's happening.
Incredible. So the numbers that caught me there, Marc, was 10 to 50 billion microparticles in mRNA vaccines. And yet if you get 60,000 microparticles over 1 centimetre of endothelium, that is enough to cause damage to that endothelium. Now, Of course, the endothelium is inside all of the vascular system. So this could go anywhere, systemic absorption. So potentially you could get this endothelial damage literally in any part of the circulatory system. And that means literally in any organ in the body.
Yes, and that's what you're finding if you do some case report searches on the internet and you're looking for endothelium leakage or vascular leakage, you will find it everywhere. There's a Japanese study that showed that myocarditis was related to endothelial leakage in the heart. But again, it goes to the heart. It can go anywhere and do exactly the same thing.
So I'd like to go back to the bodybuilders, if you wouldn't mind, Marc. What did you learn from studying bodybuilders?
Well, first of all, they're smart. They have their protocol, and their protocol is to aspirate, to potentially dilute a bit more.
This is injecting steroids.
Yes, and to inject very slowly. To inject very slowly, which is something that the world should generalize. On top of aspiration, the only way you can stop a bolus is to inject extremely slowly. Because what you do is you reduce the peak concentration that is so toxic and so dangerous.
So we've got this idea of putting the needle in, and you could damage a blood vessel. You could actually penetrate a blood vessel. You could get varying degrees of intravascular administration. But just the fact that people often give the injections very quickly means that you're more likely to damage blood vessels and get intravascular administration purely through the speed of the rate at which the plunger is depressed. Is that the thinking?
Well, I mean, the thinking is the really. I haven't really looked into the deltoid aspect of it. I know it's happening. We know it's happening, right? There are people talking about taste in the mouth. That's been known since the early 1930s, and that with pollen it had a spicy taste, or with I remember with pollen or with steroids. It's happening. However, it's happening is not really relevant to me. What's very relevant is the fact that you're doing it when you're injecting very quickly. You're doing a very concentrated push into the bloodstream. I believe even intramuscularly, it's dangerous, right? Professor Muller in Basel University has shown that every single heart is being damaged to a certain extent, which means that even if you inject intramuscularly, there's a likelihood that you're creating a small bolus in via the lymphatic system, and that is enough to create a little harm to the heart. So the idea of stopping, I don't want to talk about flattening the curve, because it has some very bad connotations. I'm sorry, but fundamentally, that's really what you want to do. You want to avoid that peak and make sure that you have the slowest level you can get, which is what as I wrote a piece, which was I was very upset when I discovered that people in the public health at WHO or across the globe are acting like bureaucrats when people like bodybuilders have protocols that are extremely full of common sense, right? And they're getting the feedback from their bodies better than anybody else, right?
So with bodybuilding, of course, there's actually oily material in the testosterone injection, isn't there?
Yes.
And if they give that into a vessel by mistake, that oil material will go to the lungs.
Yes, it creates POM.
And yeah, so what's POM? Pulmonary
oil mediated embolism.
Yeah, that's right. Yeah, I've always called that a fat embolism. You can get the same thing when you break bones and you get fatty material from long bones going into the circulatory system. And they would notice that straight away. They could clap straight away if they gave an inadvertent intravascular injection. So they know about that. And the other one that interested me there was people with multiple bee stings. They've actually found out that the people that get the severe reactions, part of the bee sting was actually in a vessel, in a blood vessel.
Yes.
And that's what caused the more severe allergic reaction.
Yes, because it's exactly the same thing. You have toxins, or you have the toxin that goes directly into the lungs. There's a little nuance with the vaccines, because the vaccines are coated, but with the steroids or with venom, when the first place it goes to is the lungs, and of course. Bee venom in the lungs creates horrendous damage there. You typically die. That's and it's very likely that many people die of that every year without anybody knowing they were stung by a bee or understanding that a bee sting killed them. So that's the big difference between bolus theory applied to venom. Or to steroids, or to pollen for that matter, and the vaccines, the anti-cancer, the vaccines that we're the COVID vaccines, sorry, is that these vaccines are coated with PEG, and that coating impedes transfection during the first moment. So, but it most likely gets rubbed off depending on how it's injected. In the arteries, if it gets injected in the arteries, or in the lungs, and then it becomes activated, right? Thank God for PEG, actually. A lot of people have been critical of PEG, but one positive aspect of PEG is actually creating this buffer zone during which time concentrated transfection doesn't occur.
So the first point was anaphylaxis, which I think we've covered. So is the second point the endothelial rupture, Mark? Was that the
Yes,
second
it
point?
is. Yeah. Yeah.
So can we unpick that a little bit in endothelial rupture? What are we talking about there? What's going on pathologically in the body, and how can this be manifested in clinical features?
Okay, so fundamentally, the mechanism of action is carpet bombing of the endothelium. Okay, so you have to understand that when you inject directly into the vein these vaccines, the instantaneous concentration on the surface of the endothelium is going to be 3,000 to 4,000 times higher than normal, than the peak normal. Okay, that's it, and it means that you are going. There's the possibility of this. When we talk about nuclear bombs, you can nuke the planet several times, right?
Yeah.
Well, here is the same time, except I think here it's up to, in my calculation, I think it was over 200 times. Okay, which is very important because transfection is hard, John. It's hard. People think transfection is easy. That's the reason the labs have put tremendous amounts of NLPs is because transfection is very low. It's hard to do. And so there's very little probabilities if you inject in the muscle that you are going to transfect the endothelium or the aorta in a very concentrated way. That's that's why most people are fine. At least they're there. But if you increase the concentration 3,000 to 4,000 times, well, if you have a 1% chance of transfection, well, you end up transfecting the entire surface. And whatever the size, if that surface, as I said, 1 centimeter diameter is about 60,000 endothelial cells, at least my estimate. That means that it's going to penetrate into that area. Then very, very quickly, T cells are going to attack them very, very rigorously and very quickly and strip it off. And that second layer, which is composed of smooth muscle cells that basically are the structure holding together the blood vessel, is going to be in direct contact with the blood. I don't know, to be honest with you, I don't know. I started looking into it earlier today, but I need to finish that up. It's very known that when that occurs, this layer just goes away. It's known, and that it will create either aneurysms, which are basically either a relief or a rupture of the artery at that level. And we all know that that's except if you're in the hospital and maybe you have somebody who can intervene extremely quickly, you die in a few minutes.
As well as that, the inflammatory reaction in the endothelium would stimulate blood clotting as well, I would imagine, Mark. The thrombosis development.
Okay, so that's the really interesting part. I had been wondering, why did you have people living for 4 or 5 months and then dying of an arterial rupture? Why didn't they have thrombosis when, I have a few friends who've had strokes within a week, and many people who have thrombosis very, very quickly. And frankly, it was a mystery to me until I got to it and I looked at the details. So let's back up a minute. It's very simple. when we cut ourselves shaving, right? What triggers coagulation is the destruction of the endothelium layer, okay? Because it makes sense, right? If the endothelium layer is not destroyed, the blood vessel is not broken. You're not bleeding. You're bleeding when it is broken.
Yeah.
The way it works is the cells that are the bordering cells of where the wound happened signal to the blood the need for coagulation factor. Okay, so evidently, the more of those bordering cells you have, the more coagulation factor you end up triggering, and that's that makes a lot of sense. Now, what's very clear is that if you drill a hole like this, right, you are not going to have a huge amount of coagulation needed. I mean, all those cells it's going to be a normal number of cells saying, "Hey, I got a cut here. I need please provide coagulation factor." However, as I was saying, take the same 60,000 cells, nanoparticles, split them into 1,000 little subgroups of 60 nanoparticles. They're going to hit a place here and here. The sum of all those bordering cells is going to be 32 or 33 times more. Now, we haven't evolved to produce that quantity of coagulation factor because it's enormous, right? Imagine, if you have a hole like that in your artery, you're already signaling for a lot of coagulation. If you need 30 times that, and potentially even 100 times that, if it's 1,000 cuts, then your body is going to produce an obscene amount of coagulation. And that explains, and I don't know if your viewers know that, but the body produces coagulation inhibitors in the areas where you're not supposed to be coagulation, right? So there's all across the body little inhibitors saying, "Hey, don't coagulate here," and they're stopping the coagulation, okay, except in the areas where coagulation is needed. But if you overload the body with coagulation factors, you end up not having enough of those inhibitors anymore. You just run out of them. Just like you run out of coagulation with thrombocytopenia, you run out of those inhibitors. And that explains why, that explains very well thrombosis, deep vein thrombosis, and strokes. And it also explains how people who've had relatively serious damage to the aorta are not dying of thrombosis and can keep up not having thrombosis for 5 or 4 months.
So that could have potentially explain the arterial rupture as well, because of the development of the aneurysm. Once you strip away the protective layer of endothelium,
yes,
there can be degeneration of what we call the tunica media, the middle part of the arterial vessel.
Yes.
And we've also looked at thrombosis there. So the third one is the third point, clotting leading to necrosis, Marc?
Yes.
Yeah.
Yes, because again, I'm going back to my San Francisco bouncing balls. Now we're getting closer to the marina. It's going down. It's more scattering across, and it's starting to disseminate. And the more disseminated it is, the better, because it is less dangerous. It's getting closer to the norm, right? And the norm is I'll explain the norm, but so but it's still, if you still have some clusters here and there, and as they enter the funnel of the capillaries, they will transfect the capillaries, and they will ask for coagulation. They will be destroyed, and the same coagulation will occur. Coagulation in the capillary means clotting of the capillary. It means necrosis behind. After that, it's all a question of severity, right? If it's a tiny element, you'll lose a myocyte here, an hepatocyte here, there. It's not a problem when it's in the muscles. The muscles can regenerate. It's a problem in the skin, but the skin is resilient.
So basically, I think what's happening here is that we're getting multiple small clots. That's blocking off various blood vessels. That's depriving the tissues that these blood vessels would normally supply with oxygenated blood of that blood.
Exactly.
And therefore, these areas are simply dying, and we're getting areas of necrosis, areas of dead tissue.
Yeah.
What size blood vessels are we talking about mostly for this pathological process, Mark, do you think?
I mean, for the most part, there's relatively small capillaries, but it's a question of how many of them are his. As I said, the same friend. I have a friend who's had 30% of his lungs destroyed, but also 100% of his gallbladder was dead, entirely dead. Okay, so it's a question of dose. How much of the dose went intravenously, how that dose went, because you can imagine there's all the scenarios exist whereby potentially they're inside the vessel and the NLP stay concentrated inside the vessel and end up staying very concentrated and transfecting one specific organ. It can be that they actually at one point scatter across and do several organs at the same time. We've seen all the possibilities are there. One thing that is driving all of this is we can be certain of one thing: the vascular system is extremely good at distributing evenly across the body and across time. It's both its content. So it's not throwing all the oxygen at one area and not in the other. It's always doing it extremely well, and that's why the adverse events are actually across the entire endothelium, because that's it's going to be pure Russian roulette where it goes.
And I think we can make a prediction here. I think we can make a prediction here, Mark, as well. This is going to give rise to a new sort of presentation and distribution of necrosis in various organs. So, for example, if your friend unfortunately needs a cholecystectomy, if he needs his gallbladder removed, when the pathologists look at that, they'll see a particular pattern of necrosis. And this is going to be a pattern which is going to become recognized. So as the pathology is done, this will be diagnosed and recognized as a new presentation of necrotic distribution. This is going to happen. We can predict that quite with some confidence, I think.
I don't know. Maybe possibly yes. What is certain is there are not all organs are created equal against this. Some are resilient. Some can regenerate. Muscles can regenerate. The liver can regenerate, and some can't. So the brain and the heart, notably, are the ones that have most trouble regenerating. So the severity is very uneven there. Another aspect that people haven't realized is the implication of the differences between men and women at that level, because our endotheliums are very different. For example, we have a muscular mass which is much greater, which creates a much higher buffer, right? I'm basically saying, I don't really care if a muscle gets transfected. it's probably going to be painful, but it will regenerate, right? It will regenerate, except if it's in a really bad situation, but it will regenerate. And therefore, men have an advantage over women in that because they are getting a bigger share of those NLPs at a population level, not at individual level. At a population level, they are getting more NLPs away from critical organs.
Yeah, because
Actually,
they have a greater muscle mass. It's a
yeah,
dilution effect.
you could see it. For example, Professor Muller, in his study, there's a huge difference between men and women in terms of myocarditis. I don't know if it's only related to that, but it certainly can play a role. The other
More
element,
myocarditis in young men than young women.
yeah, that's a different story. Yeah, I think that's more related to the vascularity of muscles.
Yeah, and the probability of an intravascular administration.
Exactly,
Initially,
exactly.
yeah.
But in the case of
Just to clarify, Mark, I think we should say that skeletal muscles themselves won't undergo mitotic regeneration. But because men have got a bigger muscle mass, the muscles, the viable muscle cells that are left will grow bigger, a process called hypertrophy. So functionally, they wouldn't notice the loss of a percentage of them in a skeletal muscle. But of course, in a muscle such as the heart or the myocardium, then that is a completely different matter.
yeah, of course.
The dead myocytes will not regenerate. There's no meaningful mitosis in the myocardium.
Yeah.
Yeah, so a very, very powerful point. So the fourth point was the fourth point, the perforation, the sieve type effect.
Yes, that's the the nuanced and sophisticated one. Because to be honest with you, not being a biologist, not being a doctor,
You
I
could have
had
fooled
no.
me, Mark. Your knowledge of pathology is incredible.
I had no idea, what, for example, what the brain-blood barrier looked like or what it was. I had no ideas, for example, that the blood-milk barrier is actually the endothelium in the breast of women, which is beautiful. Now, once you understand the endothelium as context-aware and functionally different by organ, right? So it's the same organ. It's a huge organ. It's most likely our most precious organs, and I have trouble now understanding why we are vaccinating by actually damaging this organ. In any case, we'll damage it. We might not create adverse events in each time, but we'll damage it and making it age. I think that's from an intellectual and strategic standpoint, there needs to be some thinking around this and possibly overall the vaccination techniques. We'll discuss that later. But let's go back to the endothelium and its blood tissue barriers role. We have evolved, and animals have evolved, to have these barriers play fundamentally two functions. One is stopping things from entering, and the other thing, and letting other things enter, and the other thing is letting elements out like hormones or immune cells and containing them, right? So any 5-year-old can understand that if you open a door or you break down a door, it will create problems. Okay, so what type of problems is it going to create? Well, if you start with the BBB, the blood-brain barrier, and you create a leak there, what's going to happen is you are going to let in material, more material than should, into the gray and the white matter. Now, I think I provided you with a study. I don't know if you were able to read it, but it was a huge eye opener for me when I investigated that, because the study I'm referring to draws a direct link between endothelial leakage or BBB leakage and neurodegenerative disease. And what's important is, the question is, okay, but is it the disease that's causing the leak, or is it the leak that's causing the disease? And clearly from the study, it's the leak location that dictates the type of neurodegenerative disease, i.e., if it's in the gray and white matter, it creates Alzheimer's, or stimulates Alzheimer's. If it's in the basal ganglia, it's going to do Parkinson and so forth. Now, the part that is extremely vicious about the BBB leakage is that, of course, the immune system is a marvelous. I don't know. I don't have the
physiological system.
It's an asset. It's a fantastic asset. Why? Because what people need to realize that if there's a leak, how's the leak related to age? It isn't. It isn't. So you can have a leak at 40 years old, and your immune system is going to work for you for 20 years, and you'll be fine. As long as your immune system has the capacity to strip away the amyloids, okay, with antibodies that are coming, and the macrophages basically mopping the mess that the open door has created, you're fine. But as you age and your immune system starts decaying, well, the pileup of amyloids cannot be, corrected for, and after that, well, you have Alzheimer's. Okay, and it's most likely true for Parkinson's, and the same. So that's my big fear, to be honest with you, John, is that these vaccines, not these vaccines, other vaccines in the past too, because I'm not against vaccines per se. First of all, I'm not anti-vax. I've worked for a vaccine company. But clearly here we're seeing something that is accidental. It's part of the protocol. I'm an auto guy. When you inject something to billions of people, you need to do it 100% perfect, not 99.999. You need to do it 100% perfect. And we know it's not even done 95% perfect. So that's a big problem, because we might have a huge wave of Alzheimer's. Now, what's interesting also is, once you know the leak is a problem, well, maybe you can start. You can have theories. For example, I have a friend who has Parkinson's, and it's gotten worse after his vaccines. And what I'm telling him is, well, one thing you can do is fast, because as you're fasting, you're going to give more time to your immune system for cleaning up, and you have less junk entering your brain. So you can do two things. On the one end, fast maybe 3 days a week. So or exercise. As you exercise, your muscle take up more of the proteins. Less proteins end up caught up in your brain. So that's one way. So you can actually start giving useful advice to people suffering. And the other element is, of course, make sure your immune system is always in the best shape possible, right? Take vitamin D, go out, exercise, eat properly, etc. Keep your immune system as effective as possible. So understanding what is causing things is in my view, is fundamental. And so let me continue. So you have the brain and neurodegenerative disease caused by accidental intravascular injection. That's a quasi-certainty, okay? We're not going to talk about the heart, myocarditis, okay? I'm going to talk about, of course, pregnant women, because perforating the blood placental barrier is a fallacy. It's just, you know, it's against nature. Women should not, pregnant women should not be taking these vaccines. Punto. Damaging, especially an organ that's actually growing. You know, it actually needs to grow at the same time. It necessarily clotting it, part of it, etc., is going to impede proper development, baby development, and cause, of course, what do you call them? Stillborn babies and stuff. There is another element which I knew I was having worked for an anti-HTERT cancer company. I was aware that the cells, the reproductive cells, need to be protected from the immune system. Why? Because they're expressing genes that we don't typically have daily, and therefore your immune system can consider those as non-self. Notably, your sperms and sperms can express HTERT, which is also expressed by cancer, by the way. And if T cells see that, they will attack and destroy your sperms. Now, interestingly enough, I wrote a piece, I think in April of last year on that. A few months later, the study that was showing 20, I don't remember if it was 20 or 40%. I think early on it was 40% reduction in sperm count in Israel. And that's makes a lot of sense. If you open up the doors, it's going to damage the reproductive system. And we've seen throughout the world, hopefully it's transient, that the fertility rate has gone down, and it's been going down for 10 years. I mean, the U.S. has an average infertility rate of about 10%, which means 20% of couples cannot have babies. Now, imagine if we've actually raised that another 10%.
Yes, and the pathology that you've described there, Mark, makes perfect sense. The endothelium disrupted, depending on the organ that's involved, could have all these multiple effects.
You also have endocrine disorders. Of course, if the blood tissue barrier of a pancreas happens, or a pituitary gland, or all those glands, we've seen massive endocrine disorders, and it's often caused by an overproduction. People say it's overproduction of hormones, but the reality of it might be over-release of hormones, because you don't have the containment capacity anymore.
Just like drilling a hole in a bucket, they'll leak out.
Exactly. It's as simple as that. Some of it will be transient, and is transient, because some of the holes are not big enough, but some of the holes might not, and then you would have fibrous material, and you would have leaks to a certain degree.
Mm-hmm. So moving on to your fifth point, Mark, I think that was that immune privilege cells was the next point.
Yes. Okay. So that's one of my latest insights. I must say, I'm a slow thinker. I'm a very slow thinker. For about a year or two, actually, I've been telling everybody, look, all the cells get destroyed. Right? They have to be destroyed. The immune system is there. It does its job day in, day out. There's no reason it's not going to destroy. We're seeing it. The adverse events are showing it. And on 99.99% of cells, I'm right. Okay?
So
but
99.9% of cells will express the foreign antigen if
they'll
if the recipe
they'll
for
have
that,
MHCs.
yeah.
They'll have MHCs. They will express the spike protein, and the immune system will destroy them.
Yeah, so these MHCs, the major histocompatibility complexes on the surface of, I must say, I'm with you. I thought it was on the surface of all cells.
Well,
We'll come on to that, but it's the MHC that actually supports the punches out the spike protein, isn't it? It depends the spike protein.
or bits of it. Yeah,
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 sits on
bits of it.
the MHC. So tell us about these cells that don't have the major histocompatibility complex.
Well, I mean, people have different theories about them. They call them immune privilege or not, whatever. I mean, fundamentally, they are protected by from the immune system. Okay, so they are guarded. They have a guard around them to avoid contamination. Okay, so it's hard to get to them. They're often in endothelial niches. At least in most organs, but the big cohort is in the bone marrow, and you have a pyramid of sort of like the king and the dukes and
So you've got one pluripotent cell will divide into two semi-pluripotent cells, and then they divide into
exactly, and
millions
then
of cells that populate the blood.
yes, and so it's very easy to understand. So since they're protected, the immune system is not going to attack them. So it explains two things. It explains why there's to a certain extent where you're still seeing spike sometime along after in small quantities. So that's what I've been saying all along. It's the spike. I don't really care about if there's spike 6 months later if it's in very small quantities. It's very small quantities because you have very small quantities of these cells. And most likely when they switch to a cell that becomes an MHC, if ever they continue, which I doubt they do, but if they did, they would get destroyed anyhow. So, but these cells they're fundamental, and notably they're fundamental for the immune system and for red blood cells, okay, which produce billions of new cells every day. Okay, it's that people don't necessarily know. Now, as I was saying, a good analogy is the higher up the royal cell will be contaminated, the worse and the faster the cancer it will trigger.
Because that will cascade onto all the cells beneath.
Exactly. It's my analogy with the refinery, right? If you put sand in the refinery, everything will not work. If you put it into the local depot, it will be at the local area. If you put it at in the service station, all the cars that go to that service station will be damaged. And if you put it in your car, then it will damage only your car. What's very interesting is when you look at blood cancers, well, it fits very, very well with this model. You know, you have these gigantic cells. You have these two. You have cells with two nucleus. You have of course, you have cells that have lost DNA, that have gained DNA. All those things that actually viruses have been doing to us or with us for billions of years, and that's why we've evolved. We've evolved thanks to this process. Now the problem is, in the process, many other things wrong happened, and that's what I believe we are triggering. Now I'm in the bolus theory. I'm certain of the 4, 5, the anaphylaxis and the other 4. This one is more at a theoretical level. I mean, the rest everything is proven. All the steps of the first 5 is proven. This one is a theory. Okay, it's really more. I think that's what's happening. It makes sense. all the signs are there that it would make sense. The logic is there, but I can't prove it. Okay, but it clear.
That makes sense. I can see exactly where you're getting. So it's a challenge to the world's pathologists to start looking for this effect now, isn't it?
Yes, because the one thing I was telling you about in our earlier conversation. When you look at the incidence, the yearly incidence of illnesses in the U.S., for example, it's very interesting to see that it's almost linearly aligned with the endothelium exposure. Okay, you have 2 million cancers every year, 2.6 kilos of bone marrow. You have 500,000 Alzheimer's, 1.6 kilos of brain, etc. And you end up with very few people with retinal problems because it's 4 grams or less than, or 0.4 grams, something like that. And
if that's what I thought, yeah.
Right. It's linear. So it's a bit scary. The question I have now, to be honest, 3 months ago, I would have told you I have no mechanism of action for cancer, so it's out of the question. I was not talking, as long as I don't have, now I have a mechanism of action. At the time, I thought, well, maybe it's causing cancer. I don't know, but it can't be that big, etc. Now I'm like, okay, what's the percentage? Mm-hmm. Is it 10%, 20%, 30%? Is it causing 80% of cancers? I don't know, but it has to be significant, and it's a possibility.
So the ribonucleic acid from these vaccines would still get into these privileged pluripotent stem cells.
Yes.
But they wouldn't be expressing an antigen. So the damage is done by the disruption to the protein-producing mechanisms within the stem cells rather than the external attack from the immune system. Is that the thinking?
Yes, exactly.
Mm-hmm. So I think we've covered your main points there, Marc. Is this? I think we have to emphasise one point. This is not specific to the mRNA vaccines. This is something that's been going on for some time.
Yes.
Whenever there's this transfection. So whenever there's transfection, when the genetic material from the mRNA or the adenovirus vector vaccines get into a cell. But other vaccines like smallpox, for example, will also get some of the antigen going into the cells.
Exactly.
So there'll be antigen associated with a cell, and the immune system will attack that.
Exactly.
Regardless of where the antigen came from.
The immune system doesn't care of the vaccination technique. As long as it's got a laser telling him destroy this cell, it could be an attenuated virus. It could be a virus-like vaccine. It could be a DNA vaccine. It could be an mRNA vaccine.
You know, I hadn't realised that there was a transfection process with the previous generations of vaccines, that you get some antigen that's actually associated with the surface of the cell.
That's the reason they don't need adjuvants. But again, let's go back to the root cause. The root cause is a bolus going down the vascular system, which is not, from a quality standpoint, something that should occur. Okay, mm-hmm. It should never occur, and that is related not to the. I know a lot of people are going to hate me for that because everybody wants the. A lot of people. Are trying to find a guilty person. Somebody has created a theory that it's poison, and frankly, maybe the designers could have been a bit smarter. I would agree with that, but they certainly didn't design a poison, right? Because if they did, everybody would be dying, so the really important thing is going back to your aspiration technique message, right? You've been hammering it for over a year and a half or so, I believe, and I have also being saying the same thing. I would like to add a dimension to it, which is the slow injection. But what's important is this is not anti-vax versus vax, pro-vax. This is whoever wants to get vaccinated. But let's do an injection that's appropriate and in line with the mechanism of action of the vaccine. Otherwise, what you're doing is you're poisoning the person, or you're hurting the person. And one thing that's very dangerous is preconceived ideas. The preconceived idea that has been in the medical industry for 100 years, which is 1 in 10,000. I know you're one of the rare person that said it's 1%, I think. And I think you're very close, because when you think about it, 5% go intravenously. But if you look at the studies on the steroids, they're saying 20% are severe. So actually, there is indeed 1% of the shots that are very severe and extremely dangerous, or more dangerous than the others. But still, the other 4% are still very dangerous, notably for Alzheimer's and equivalents.
Yep. Marc, I think that's really quite incredible. That one theory explains all of these pathologies.
Yes.
And I would appeal to the decision makers around the world to assume that this is true unless they want to prove otherwise.
Well, they're going to have problems proving it wrong.
I agree, but the onus of proof is now on them. So for decision makers not to take this on board now, I believe, is negligent.
Yeah, I mean, Denmark, and I mean, let's be honest, Denmark, Hong Kong, and Germany very lately, but still they did it in February. They all reinstated the aspiration technique.
I don't know how universally it's been done in Germany. I think it's official now, but I'm not sure it's got down to all levels yet.
That's the whole the compliance. But again, if you don't explain to people what's happening, how dangerous this is, right? I've always said vaccination is a medical procedure. Any medical procedure is not mundane. It's very, very serious. And frankly, when you go through my theory and you realize that 60,000 nanoparticles is enough to kill you, and they inject 10 billion at the minimum, you realize how your life can hold on a threat.
Absolutely. Marc, is that the main points that we wanted to cover? I think we've got the main bits there.
I think I've covered the main points I wanted to cover. I have plenty of other things to talk about, but this is the core of my work.
And all the reading and literature, of course, will be given to this. So Marc, amazing piece of work. I've read some of your materials. I'm going to go back and read more. Do read Marc's materials. They make perfect sense as I understand this. And we know you've talked to other more senior people than me. You've talked to pathologists and people that know this in more detail, and they agree with your thinking. And I think it's really impressive. And but I'm just delighted that you've chosen to come on the channel to talk about it.
I was hoping to. There's very few people believing into this theory. Let's be honest, John, for reasons because it goes against a lot of preconceived ideas. First of all, the idea that you would have one theory that explains everything is to them is hurt. It hurts their intelligence. And second, that a non-biologist would come about that is even worse. So I've taken a lot of pushback, sometimes friendly pushback, sometimes more hostile pushback. But frankly, it does explain everything. I hope it becomes mainstream for public health, because that means that possibly we can eradicate an enormous number of illnesses that we know about. I mean, I'm not saying 100% of the illnesses that we address today are related to the bolus, but maybe a big chunk of them. And we know I've been fighting against the adverse events because I've seen them very early on. I detected them in the epidemiology, as I told you the other day, and it's been morally very heavy, personally, to be honest, to be alone.
You paid a price for this, Mark. I know that.
Yeah, it was very hard, and it was good to get supports from people like Nick Hudson at Panda, who have been very supportive. Now it's coming out. What I don't want is that the bolus theory gets actually dust under the carpet, because if we do that, we would have lost this crisis to make it better. And a lot of people have been blaming the circulating spike protein. It's been the most prominent. I wrote a piece where I found 12 falsifiable hypotheses on spike protein. It cannot fly, right? The biggest one of them is, of course, antibodies will bind and work. Why would they not work this time? If we can get this together with a few others, I know Brett Weinstein had mentioned your work and my work on Joe Rogan a few weeks ago. If together we start, creating mass, it would be great to have some impact. If we can help people. That's why I went into that 3 years ago. So thanks for listening to me.
No, it's an amazing piece of work. But of course, part of the problem is doctors and people around the world might have to admit they haven't been quite right all this time. I'm reminded of Philippe Semmelweis in the 1840s, who said that doctors' dirty hands after post-mortems were causing puerperal fever in women. And of course they were. The death rates were horrendous. And they said, what are you talking about? We're doctors. We don't kill people. We make them better. And they did learn, but after many more deaths.
Yes, and I think that's most likely what's been happening for quite some time.
Mark, thank you very much. When there's more material, of course, you're welcome back anytime. Really appreciate it.
Thank you very much.
Thank you for coming on.
Thank you, John. I really enjoyed the conversation.
Great. Thank you, Mark. Brilliant.